Module number 4 of Milestones in Algology will discuss the major barriers for the advancement of this medical discipline. The major barriers are pain assessment, pain education, and pain research. Pain assessment is clearly one of the three major barriers to proper pain therapy. Pain assessment is a major barrier to pain therapy because healthcare professionals assess diseases by interpreting objective findings, using measuring devices such as a thermometer or a sphygmomanometer, using laboratory tests and imaging. Pain measurement is, on the contrary, a subjective report. One can argue that pain could be the easiest disease to assess if, and this is an extremely important if, every patient could be completely trusted, and if all patients would know how to report their pain in a standardized manner. Our brain is an effective endogenous device to assess pain, as it not only alerts an individual of the presence or absence of pain, but it also of its possible location, intensity, and its characteristics. As we're beginning to visualize alterations of the brain experiencing pain, in the future we may be able to use these changes to evaluate not only pain, but also its relief. Almost 100 years ago, the Visual Analog Scale, or VAS, was developed to measure subjective experiences. As the interest in pain therapy grew in the 50s and 60s, the need for a pain assessment tool became evident. The Visual Analog Scale was adapted to assess pain. The VAS is a 10 centimeter long line. At one end is written "no pain," and on the other ends the worst imaginable pain. The line is used most often horizontally, but it can also be used vertically. The patient is asked to mark on the line the intensity of the pain in relation to the two ends point. The distance between no pain to the marked point is measured in centimeters, and the corresponding number is interpreted to represent the intensity of the pain. Soon it became apparent that more comprehensive tools were needed. In 1975, Ronald Melzack published the McGill Pain Questionnaire, which he reissued in 1987 as the short form McGill Pain Questionnaire. It consists primarily of three major classes of words that describe sensory, affective, and evaluative experiences, and are used by the patients to report the subjective pain perception. It also contains an intensity scale and other items to determine the properties of the pain experience. In the 80s, Wong and Baker developed the FACES rating scale to help assess pain first in children, then for people who could not understand the VAS or the numeric scale. In 1989, Cleland published the Brief Pain Inventory, and many other scales have been developed since then. However, after the year 2000, the 0 to 10 pain rating scale became the most frequently used. The reason for this is that in the year 2000, as pain assessment and treatment continued to be greatly overlooked, the Joint Commission proposed that pain be made the fifth vital sign. Because of this proposal, to the establish four objective vital signs, in other words, temperature, heart rate, blood pressure, and respiratory rate, the subjective pain report was added. They suggested to use the numeric rating scale 0 to 10 to report the intensity of pain. The numeric rating scale from 0, no pain, to 10, the worst imaginable pain, is the most frequently used scale. While many patients understand the scale, many others do not. Some patients report pain to be 15 or 20, while the highest rating has to be 10. Others will report an 8 or 9 pain, but if asked to rate the pain using mild, moderate, or severe adjective, we report the pain to be mild. This poor understanding of the numeric rating scale seems to be more frequently in patients suffering from chronic pain. The verbal rating scale is also sometimes misunderstood. At the question, "Is your pain mild, moderate, or severe?" some patients will answer, "I am in pain," and still not able to rate the intensity of the pain. One pain assessment that I use in combinations of others' rating scale is if the pain is tolerable or intolerable, because the real aim of pain therapy is to make unbearable pain a bearable one. Further information can be gathered by asking if the patient can be distracted from the pain, or if the pain is so severe that the patients cannot concentrate to perform even the most routine functions. Finally, we can ask if the patient is satisfied or unsatisfied of the pain therapy. By obtaining all these informations, we may get a good idea of the patient's pain experience as well as the effectiveness of the pain therapy. A better method of pain assessment is the one reported in the study published in 1995 by Serling, a collaborator of Charles Cleland. In a multi-center and multinational study of patients suffering cancer pain, the researchers associated the 0 to 10 numeric rating scale with an interference in the performance of activities of daily living. In this study, an average pain score up to 4/10 is considered by patients mild pain with little impairment. A score of 5 and 6 is considered moderate pain, and it is associated with a significant impairment consisting in difficulties in sleeping, decrease in activities, change in the mood of the patients, decrease in working capacity, and decrease in the enjoyment of life. A score of 7 to 10 is considered severe pain, with all the interferences caused by moderate pain, plus inability to walk and inability to having interactions with family members, making the patients a true invalid. A very interesting result of the study is that patients did not consider the pain severity scale to have a linear and gradual relationship to the interference with the activities of daily living. The impairment of daily functions may be a better and more objective measure of pain, and it underscores its negative effect on the patient's life. In 1986, Vaona similarly reported that there was not a linear correlation between two pain intensity scales. He compared the verbal descriptive pain scale, mild, moderate, severe, and excruciating pain, with the visual analog scale, which, as we have previously described, is a 10 centimeter long line with the two endpoints being no pain and the worst imaginable pain. In this slide, the Italian terms are used, nessun dolore and il più forte dolore. The hypothesis was that the numeric cut points of each of the four different descriptive pain intensity would be equal to 2.5 centimeters. Instead, the correlations of the verbal descriptive scale to the visual analog scale was as follows: mild pain up to 4.2 centimeters, moderate pain from 4.3 to 6.8 centimeters, severe pain from 6.9 to 8.5, and excruciating pain from 8.6 to 10. Unfortunately, this study was published in a little-known Italian pain journal and found little recognition outside of Italy. However, if these findings could be confirmed, they would call into question the results of most pain studies. Pain studies have used the numeric values of the visual analog scale or the numeric rating scale for statistical analysis. The assumption has been that there is a linear relationship among these numeric values. Instead, the relationship is certainly not linear. Pain education is the next barrier, and I like to argue that the absence or poor pain education is the most important barrier for the advances and improvements of this discipline. Lack of pain education prevents the healthcare professional to apply present knowledge based on past and current pain research, even if pain research has been quite limited due to poor funding support. Therefore, even the available tools of pain assessment, with all their limitations, are very seldom used, as they are unknown to the great majority of primary care physicians. Pain research, as it will be discussed later, is grossly underfunded. The poor educations on pain issues, also greatly present in our society, which includes the American people, the media, and the politicians, fosters, as I have mentioned earlier, the perpetuation of myths, biases, and misconceptions. As funding for pain research is dependent on the understanding of the major public health impact caused by this disease, lack of proper knowledge by the above-mentioned party has greatly impacted in a negative way the support of pain research for decades. Ben Rich has written extensively on the subject of the lack of pain education, mostly by healthcare professionals, and I like to share with you some of his reflection-stimulating thoughts.
The knowledge deficits of physicians concerning the assessment and management of pain have been documented in the clinical literature since at least the early 1970s, yet persistent calls in that literature for reform in the health profession's curricula have been ignored with impunity. This failure or refusal to modify curricula to ensure that graduating healthcare professionals, in particular physicians and nurses, possess minimal core competencies in pain assessment and management constitutes the cultivation of ignorance in this area, for which the responsible parties should be culpable. Such culpability is recognized in the law, which traditionally provides that an individual can be held accountable not just for what he or she actually knows, but also for what, in the reasonable exercise of due diligence, he or she ought to know. Indeed, this concept of the culpability of cultivated ignorance goes to the very core of the concept of a professional, which is the commitment to lifelong learning. Remarkably and lamentably, we continue to graduate from the medical and nursing schools of this country significant numbers of young professionals who are unable or unwilling to meaningfully distinguish between addiction to narcotics and physiological dependence on opioid analgesics for the relief of severe and persistent pain. According to a former director of the National Institute on Drug Abuse, the confusion between the use of narcotics by street addicts influences the attitudes and behaviors of dispensing practitioners, patients, and their families, as well as policymakers who regulate the availability of these drugs.
A seminal study was published in 2009. It reported the result of a Canadian survey of several health-related professional schools. This slide summarizes some of the salient results. During 4 years of education, the number of hours devoted to pain education were as follows. Veterinary students received an average of 87 hours. The range was 27 to 200 hours. Nursing students received an average of 31 hours, with the range of 0 to 109 hours. Medical students received an average of 16 hours. The range was 0 to 38 hours. Several studies in the United States have reported average of 9 to 11 hours of pain education during the 4 years of medical school. It is clear from this Canadian survey that there is more interest in treating animals in pain than humans. I have already mentioned Ron Melzack, a true scholar with multiple interests. These include not only laboratory pain research, but also on the field, such as reporting on a craniotomy performed by a shaman on an awake member of a primitive tribe to relieve the patients from headaches and evil spirits. One of his other great interests is education, not only related to pain, but in its widest sense. For instance, he collected and transcribed oral legend of the Canadian Eskimos, stories that he collected in a printed volume entitled The Day Stuck Became a Hunter and Other Eskimo Stories. In 1990, he wrote an article in the Scientific American entitled The Tragedy of Needless Pain, in which he reported that the scores of patients suffering incapacitating pain had to be attributed to the reluctance of physicians to prescribe morphine, and this reluctance was fostered by poor educations of physicians on pain medicine. The poor pain education of healthcare professionals, denounced by Melzack in 1990, is unchanged, as disclosed by the Institute of Medicine report of 2011. Today, the great majority of primary care physicians, family medicine, internal medicine, and pediatricians, are not competent to treat patients with chronic pain. However, 40% of patients' visits are triggered by a pain condition. A survey of 500 primary care physicians in 12 academic medical centers found that only 34% reported feeling comfortable in treating patients with chronic non-cancer pain. However, the report further states, physicians' belief about their ability to manage pain do not always match their actual competence, and physicians may not recognize deficits in their pain care knowledge. This last statement implies that the authors of the report believe that in reality less than a third of primary care physicians are competent to care for chronic pain patients. Poor education in algology is not only responsible for the undertreatment of pain, but at times for the overtreatment. that can have equally tragic consequences. In an article published in 2011 by Ben Rich and his associate, they reported on 35 cases of prescription drugs overdose that went to trial. 20 of the patients died due to overdose, and it was recognized that in 75% of the deaths, the fault was to be attributed to the physician. It can only be deduced that the reason for this tragic outcome was poor education of the physicians about pain therapy. Another major barrier to the advancement of algology is the persistent underfunding of pain research. The Institute of Medicine report, Relieving Pain in America, states that in 2010 dollars, the annual cost of pain to the American society was of about $600 billion. In comparison, the annual cost for heart diseases was of about $309 billion, for cancer $249 billion, and for diabetes $188 billion. To compare more easily the annual cost of each of these diseases, the numbers can be plotted as bar graphs. One logical assumption would be that research funding by the federal agencies for each of these diseases would follow a somewhat parallel trend. Instead, we realize from this slide that the federal research funding for pain is at the lowest level, less than $500 million a year, while for heart diseases it is in the order of $2 billion a year, for cancer it is over $6 billion, and for diabetes it's over $1 billion. I'm not suggesting that cancer research should be reduced, but clearly pain research must be drastically increased. If comparable research funding should be provided for the relative cost to society caused by a specific disease, then the funding for pain research, if compared to cancer research funding, should be in the orders of about $15 billion every year. Module number 5 of Milestones in Algology will discuss some ethical considerations related to the present treatment of pain, as well as describing the concept of torture by omission.